So our first case is an 8-year-old Thai girl with prolonged fever. Okay. So she is an 8-year-old girl. She has no known underlying disease. She was living in Chiang Mai, which located in northern Thailand. 2 weeks before admission, she presented with fever, fatigue, and poor intake. She also had skin lesions on the face and trunk, which I will show you in the later slide. At that time, she was hospitalized at primary hospital, and the initial workup showed low hemoglobin, only 4.9, and low white blood cell count, and the platelet is as shown. In Thailand, in the case with subacute fever, we will also work up about tropical infection. But in this case, the dengue, scrub typhus, and leptospira was all negative. And the treatment at that time is empirical with ceftriaxone and received blood transfusion. However, after the treatment for a week, she still had a persistent fever and skin lesions, and then she was referred to the tertiary care hospital. For the physical examination at tertiary care hospital, she had fever, and the measurements show underweight and height. Also, other side is mild pallor and whitish lesions on hard palate and tongue. And hepatosplenomegaly and tip of spleen also can be palpated. Skin lesion is generalized multiple erythematous papules with some central umbilication. This slide shows the clinical pictures of this case. As you can see here, you can see the whitish lesion on her palate, and the skin lesion is like umbilicated papules on her face and trunk and also extremities. So the problem list now here is an 8-year-old Thai girl with prolonged fever and multiple umbilicated papules, failure to thrive, oral thrush, hepatosplenomegaly, and the lab CBC show pancytopenia.
So we're going to take it across to our panelists and put you on the spot. So I don't know who wants to go first. Fatima, do you want to?
Well, first of all, in Canada, I think we consult tropical infectious diseases. But because again, in Canada, we don't have a lot of these, whenever it's prolonged fever, the epidemiology is usually in a return traveler, so we would consider our larger differential. But I think just given the nature of the lesions, we would absolutely test this person for HIV because of the failure to thrive and poor weight. And then we would look at all the potential opportunistic infections. And the nature of these disseminated lesions makes us think of disseminated fungal infections, so disseminated blasto, disseminated histo. It doesn't quite look like sporotrichosis, but I think our first impression is a disseminated type fungal infection, not so much bacterial. So I think blasto, histo, potentially penicilliosis, and our next step in our setting would be to go to a skin biopsy and try and document that.
Yeah, so maybe just, Victor, do you want to maybe comment from a...
Yeah, thank you. And just to add on, because of the wasting, as you could see from the pictures, especially the legs, the girl was extremely wasted. And also, when you look at the persistent fever, the other differential that I would add on is disseminated TB, because that happens, and especially in the context of advanced HIV, that's something to look at. Also, the oral lesions suggest candidiasis, probably also extensive, may have extended to the GIT, maybe esophageal candidiasis. And I agree the skin lesions are also very suggestive of a fungal infection, so probably disseminated fungal infection of sorts. So all these would come into the picture.
Okay, so
can I add something?
Yeah. Sorry. Yeah.
No, very briefly, another possibility for the skin is if we're thinking on HIV, obviously we're at the HIV conference, it could be molluscum. So we see, disseminated molluscum in advanced HIV disease, and this could be as well.
So again, giant molluscum is something we often see, and also sometimes, if you look, there may be some purple discoloration of the palate.
Yeah.
Sometimes worrying around Kaposi sarcoma.
Yeah, Kaposi sarcoma.
So again, thinking about multiple different infections, especially if this is an advanced HIV disease.
Yeah.
Yeah. Yeah, so as we discussed that we should suspect immunodeficiency, and the first, usually we will seek for a secondary immunodeficiency such as a HIV infection. And as we discussed about a clinical picture of this patient is quite compatible with systemic infection. And for the skin lesion, as we differential diagnosis about a systemic fungal infection in Thailand, thalaromycosis, histoplasmosis can be found, and other kind of fungal infections such as cryptococcosis, or as Doctor mentioned about molluscum contagiosum or mpox. However, in this case, they deny about a sexual history of sexual abuse. So we also have additional history. Her mother is people who living with HIV and was diagnosed in more than 10 years ago. And during this pregnancy, she, per history taking, she said that she had good adherence on antiretroviral treatment. And the patient was born at the primary hospital and formula fed. No history of breastfeeding, and she also had been testing on HIV by anti-HIV test on at age 18 months, and the result was shown negative. She denied history of sexual abuse, and there is also a history of a household TB exposure from her older brother who had pulmonary TB 1 year ago. And for the clinical progression, the investigation at tertiary care hospital show mild anemia and low white count and low platelet count. And the testing for anti-HIV show reactive, which is positive result. And her oral lesion KOH staining was positive with compatible with candidiasis. For skin lesion, the right stain did not show any organism, and the blood culture for aerobic fungal and mycobacterium was performed, but pending result. After we know the HIV result, we also send the test for CD4 count is only 10, and the viral load is very high, 1.7 million copies per mil.
So going back to our panel, and maybe Pablo, speak, from the experience that you presented from the empirical data, really around, what in terms of treatment and also prophylaxis for advanced HIV disease, and certainly this child has really severe immune suppression, but also severe symptomatic disease from HIV. So in terms of your setting, both what would you treat empirically and what would you treat prophylactically? What prophylaxis would you put on?
Okay, so too many questions, but so obviously this child, as was said before, has HIV and now is clearly a full advanced HIV disease, clinically and with a very low CD4. So I agree that we will need to look what to treat initially. So obviously started on antibiotics, broad spectrum, we usually do, although you don't have anything. Then it seems there's a brother with TB, so it was mentioned by Victor, disseminated TB, obviously, and is so much immunosuppressed that it might be in the blood, but obviously we will need to do an in-depth analysis. I think now we have, for these advanced disease children, we have the urine TB LAM, which is useful. Obviously, we will go for different samples for gene expert, probably stool, plus nasopharyngeal aspirate if you don't want to go for gastric lavage. And then obviously, you need a chest X-ray to see if there is any evidence of pneumonia. You would treat, obviously, pneumocystis initially on top of cotrimoxazole, on top of the antibiotics. And then the other possibilities is seeing those CD4. The idea you will go into not only TB, but atypical mycobacteria. You would be worried because CD4 is below 50. And even you have to think on CMV disease, that obviously is a problem with such a low CD4. So you would think on increasing the study for TB, atypical mycobacteria, and CMV to decide if you treat or you prevent those. Over.
Maybe just, Tanui, do you want to add to that?
I think one of the issues that I would like to raise is about diagnosis, that at 18 months her HIV antibody was negative. She just acquired later on. And I think the key point in this one is the involvement in bone marrow. So if possible, if you're in settings that can do bone marrow aspiration, it might be a way to get diagnosis more precise while you're waiting for culture from blood to come back. Sometimes we can see the organism in bone marrow aspiration and stain. So if possible, we might consider to do that. Thank you.
Yeah, then maybe the only other thing I'd add was probably cryptococcal disease and doing a CRAG, both on blood and potentially doing it on CSF, and then you're making the decision. Yeah.
No, I think it's a fantastic suggestion, although we always discuss if below 10 years there is crypto, but I think we would do as well because she has no CNS symptoms as far as I know, but obviously such a low CD4, yeah, a CRAG test will be doable, yeah.
Great.
And so for the progression, the blood culture report the yeast-like organism as you see in this slide. And the yeast-like organism, this one is also had a central midline septum which compatible with Thalaromyces malnephii. So given the diagnosis of H1 HIV disease and also the thalaromycosis, we look for the possible opportunistic infection. Chest X-ray show right perihyral infiltration, but the gastric lavage for AFB and genes experts, Mycobacterium tuberculosis was not detected. And we also suspect about disseminated tuberculosis. So we sent the urine TB lamp and it was positive. And I think most of us know that the WHO recommended that in inpatient setting, you can use the lateral flow urine lamp to assist in the diagnosis of TB disease. For example, in this case, who has a HIV infection with advanced HIV disease and very low CD4 count, it's very helpful for the diagnosis. And we re-evaluate her symptoms again. She had abdominal discomfort and hepatosplenomegaly. So the CT abdomen was performed and show multiple matted enlarged mesenteric lymph nodes, which are probably tuberculosis lymphadenitis. We also work up for another opportunistic infection, and the serum cryptococcal antigen was negative. Hemoculture for MAC was no growth, no evidence of CMV retinitis, and other serology, hepatitis C or syphilis or hepatitis B was normal. So the final diagnosis in this case is the girl who had AIDS with opportunistic infections of disseminated thalaromycosis, intra-abdominal tuberculous lymphadenitis, and oropharyngeal candidiasis. And for the treatment, for the specific treatment, for disseminated thalaromycosis, we give induction phase with, actually it will be recommended with lipoampho, but in Thai setting, we still have limitations, so we use amphotericin B for 2 weeks as induction therapy, and then followed by a consolidation phase of itraconazole for 10 weeks. For intra-abdominal tuberculosis lymphadenitis, we give anti-TB regimen, and we also start antiretroviral treatment after the opportunistic infection for 2 weeks. At that time, the dispersible DTG was not available, so we used the film-coated tablet and increased the dose of the dolutegravir to twice daily because the drug interaction with the itraconazole. And in terms of prophylaxis, after complete the treatment of thyroidomycosis, secondary prophylaxis should be also consider give the itraconazole until CD4 more than 100 at least 6 months, and other primary prophylaxis for PCP and MAC. So I will do briefly, okay.
Maybe can we just pause here for 1 second? I have just one simple question as to the tuberculosis diagnosis in this highly immunocompromised patient. Would we be very happy to say this is sort of limited to the lymph nodes, or are we rather thinking this could also be disseminated TB? And I wondered whether like a brain scan has been done to exclude any sort of lesions, tuberculomas in the brain, because we've seen quite a few patients immunocompromised who, without any neurological symptoms, would show tuberculomas on the MRI scan.
In our setting, we would actually do a PET scan to look for multi-system involvement, but that's a very resource-rich setting answer. So I'm curious what my colleagues will do.
Yeah, they only yes, from the outset, there were indicators that this was, even clinically, that was disseminated TB. But about involvement of, let's say, the CNS or other cases, one would need to have some symptoms probably, but because we don't routinely do CT scans or other things like that, unless there is any indication of any sort. She was fully conscious, no neurological signs of any sorts, so I wouldn't think about TB meningitis, but chest x-ray showed some lesions as well as the ultrasound, so at least there is abdominal and chest involvement, and the urine TB LAM is positive. So that by itself would be disseminated TB. The regimen that was chosen is adequate for that, and then you monitor and see response. The only change to that regimen would probably be if one is suspicious of TB meningitis or involvement of the bone, for example, if there is osteoarticular TB. So because of the two that are clear, chest and abdominal TB, the regimen would cover and wouldn't do any extra investigations for that.
Yeah, thanks. So again, I think it's really around looking as extensively as possible to see the extent of the disease. You just, yeah, you can.
Yes, thank you. But in this case, they didn't perform the CT brain. Yeah. And currently, the patient is still in the follow-up period. However, her adherence on ARV is very poor, and she just, I just asked the primary physician, and they said that she just was hospitalized again due to fever, and currently still on the workup about the cause of this episode of fever. Okay. So I will talk a brief review on thyroidomycosis, which is an invasive fungal infection caused by Thyroidomyces malefii, or formerly named Penicillium malefii. Is endemic in the northern part of Thailand or southern part of China, and also can be seen in other regions such as East Asia, in Hong Kong, Taiwan, or in South Asia, in northeastern India. And HIV is a major risk factor for this infection, and in individuals who have low CD4 count less than 100. And disseminated infection is the most common manifestation, as you've seen in this case. However, the skin lesion, which is the most specific, but it is the late manifestation and can be found in 40 to 70% of patients. And also, tuberculosis is a common co-infection that can occurring with thyroidomycosis. It can occurring up to 1/5% of patients in highly endemic regions, which can be complicated disease management because of the drug interaction of itraconazole and rifampicin. So in the setting that you can do the therapeutic drug monitoring, we should monitor the itraconazole level. And for the diagnosis of thyroidomycosis, the presumptive can be from microscopic examination, the definitive diagnosis from histopathology or isolation of organism from culture. And another diagnosis is antigen detection, MP1P ELISA, which is very beneficial for the early detection. It can detect subclinical infection and is in the clinical study to use this one to diagnose and give early empiric treatment. So in summary, HIV-related OI are caused by a variety of pathogens and associated with low CD4 count, and disseminated thyroidomycosis is the common manifestation in people with advanced HIV in highly endemic regions. And using urinary TB lamp to assist the diagnosis of active TB is useful in patients who had low CD4 cell counts. Thank you.
Great. Thank you very much. I think again, I think this case does highlight the complexity with management of children with advanced HIV disease, and really much of our mortality related to HIV is now driven by advanced HIV disease, and certainly prevention of children before they reach the stage, but also the management of these children can be very complex. And I think the main thing is that you do need to think about multiple different infections. Don't get happy with just one. There may be multiple different things happening at the same time, which actually does complicate your treatment tremendously, because you're going to have to treat with multiple different drugs that interact with each other. And I think hopefully there will be some progress with this child, and with good treatment, immune suppression will improve. Thanks. So.